Hello everybody. Good afternoon to those of you in Europe. Good morning, good evening to wherever you are in the world. It's a great pleasure to have you all with us here for this latest EMAS webinar on menopause in cancer survivors managing complex care. And you'll all agree this is a very important topic that we need to try and understand a bit better, and I've got two fantastic speakers with us this afternoon. The first one is Dr. Professor Petra Stute, who is the current EMAS president, needs no introduction. She's Deputy Director and leading physician of the Gynecological Endocrinology and Reproductive Medicine and Director of the Menopause Centre at the Department of Obstetrics and Gynecology in Sepsville in Bern, Switzerland. She achieved her medical degree in 1998 from the Justus Liebig University Gießen in Germany and completed a doctoral thesis in 2001. She's board certified in Germany in both gynae endocrinology and reproductive medicine. And she'll be speaking first, and following her we'll have Dr. Jenifer Sassarini, who is a consultant gynecologist at Glasgow Royal Infirmary and honorary clinical associate professor at the University of Glasgow, where she was awarded her PhD in 2014 on the study of vascular pathology of hot flushes in menopause. She leads a dedicated clinical service in menopause and has contributed to local and national guidelines. She's a Greenblatt Prize winner in 2011 and again in 2018. And in 2024, she was awarded a Senior Research and Innovation Fellowship to support clinical research in partnership with the Scottish Government and the Chief Scientific Officer of Scotland to improve the lives of women living with menopause symptoms. So two fantastic speakers, very well qualified to tackle this subject, and now I'd like to hand over to Petra.
Now it should be fine. Is it okay?
Yeah,
Okay,
good.
wonderful. Okay, thank you very much, Tim, for the kind introduction. And I'm going to start with the topic specific needs for cancer survivors and when can MHT be used. This is my disclosure, and here is my agenda for the next 20 minutes. So first of all, I would like to talk about the three clinical challenges we are facing when we are managing cancer patients in the context of menopause care. And then I would like to provide this solution, which I just invented this term Menoprotect. And then I would like to share with you two cases. The first one is a Hodgkin lymphoma cancer survivor below the age of 40. And the second case, or these are actually two cases, are two gynecological cancer survivor at the age of 45 plus. And then I will conclude with a take-home message. Okay, so what is the first clinical challenge? Or the other question is, what is the actual problem with estrogen deficiency? And you are very well aware of all these problems that may come from estrogen deficiency. First of all, a lot of women will suffer from a lot of menopausal symptoms like vasomotor symptoms, mental disorder, insomnia, cognitive impairment, or other symptoms like genitourinary symptoms of menopause. And on top of this, women with premature ovarian insufficiency or early menopause, they also have an increased risk of chronic non-communicable diseases like osteoporotic fractures, cardiovascular disease, diabetes, dementia, and an overall higher risk of dying earlier. And here, the unique or first-line treatment for those women is systemic menopausal hormone therapy. And now we already come to the second clinical challenge, which is that there are, as you all know, contraindications to systemic MHT, like, for example, breast cancer and other hormone-dependent malignancies, like endometrial cancer and some ovarian cancers. And and this means that systemic MHT is only safe in cancer survivors with hormone-independent tumors. And on top of this, we have a third clinical challenge, which is that long-term risks associated with cancer treatment, as well as with estrogen deficiency, address bone health, heart health, and brain health. Okay, and now the solution or the management, that's probably the more proper term is, I just called it Menoprotect. So that's an invented term. And the idea came when I had a discussion with my colleague, Professor von Wolf, who's the head of the reproductive center in our clinic, that we were talking about the patient's treatment journey of fertility preservation and endocrine menopausal care. So hopefully every woman who is diagnosed with a cancer during her reproductive life stage will hopefully be referred to a fertility center where she will be counseled on primary fertility preservation. So this is what we call the mandatory first stop before chemotherapy starts. And then if you want to find out which chemotherapy has what impact on ovarian function, you can have a look, for example, into his book where all the different chemotherapies are presented. And then the idea is that if chemotherapy is through, that every woman would have a secondary mandatory stop at the fertility center 1 year after chemotherapy. And this is the optimal time point to find out more about her ovarian reserve. And then there are three possibilities. One option is that she has a good ovarian reserve after her oncological treatment, so then no intervention is necessary. The second option is that she has a borderline or low ovarian reserve, and then the secondary fertility preservation could be an option. Or maybe she already has a low or very low ovarian reserve, and then that's the time point when I come in with endocrine and menopausal care. So how do we address those women, or what do we understand with the term Menoprotect? So first of all, we have to evaluate ovarian function, we have to evaluate menopausal symptoms, and we have to evaluate bone and heart health. I'm going to focus now on the evaluation of ovarian function. So we have to take into consideration 5 parameters, which is FSH, estradiol, AFC, AMH, and the menstrual cycle profile. And then women with cancer during her reproductive life stage may fall into one of the 3 categories. So good ovarian function, borderline ovarian function, or very low ovarian function, which means that she fulfills the criteria for premature ovarian insufficiency or early menopause. So let's think about these 3 scenarios in women who was treated for Hodgkin lymphoma and is still below the age of 40. And before I start thinking about the different ovarian reserve categories, my first question would be, does this woman have a cancer type, which is a contraindication to any hormones or not? And to answer this question, one of the latest papers is that from Martha Hickey, published in The Lancet last year. So here we see different cancer types, and all the cancer types that are in green, for those there's no contraindication to prescribe MHT. And as you already see, lymphoma is one of the cancer types in which we can prescribe MHT. There are other cancer types, like for example gastric or esophageal cancer, where we know that estrogen receptor expression is associated with a worse prognosis. So here the recommendation would be to avoid MHT. And then there are also other cancer types, like for example bladder cancer, where there is not so much data out there on MHT use after this cancer type. And this is a situation where individualized discussion should take place, and maybe a hormone receptor expression analysis of the tumor may help. Okay, but in our patient, we already know now that lymphoma would not be a contraindication towards MHT. Okay, but now we have to categorize this woman. So let's say this woman comes for her secondary mandatory stop, and we do an evaluation of her ovarian function. Let's say Fertiprotect, this topic is done, and let's say her ovarian function is good. She doesn't have any menopausal symptoms. We have referred her to the oncocardiologist, and here the cardiologist also found a normal status. So here the recommendation would be contraception counseling, and then a next stop after 1 year. Let's imagine the same patient has now a borderline ovarian function, which means she does not yet fulfill the criteria for premature ovarian insufficiency or early menopause. She has mild menopausal symptoms. Again, she was referred to the oncocardiologist, and here everything is fine. So now we have different options. So first of all, we know, as with lymphoma, it's absolutely fine to prescribe hormones. So again, we have to discuss contraception. And if she needs contraception, we could prescribe an estradiol containing a combined hormonal contraception. If she doesn't need any contraception, we could also consider a low dose sequential estrogen progestogen MHT, like for example, Femostone 110. And then she would come back in 3 months to find out if her menopausal symptoms are better, and if everything is fine, she would come back after 1 year. Now, if the woman falls in the third category, which is very low ovarian function, which means she may fulfill the criteria of premature ovarian insufficiency, and she also has moderate menopausal symptoms, and because of POI, we also referred her to a DEXA scan, and here the DEXA scan already revealed osteopenia. She was also referred to the oncocardiologist, and here everything is fine. So again, we have to talk about contraception, because even with POI, the chances to become pregnant are not zero. So if she does not want to become pregnant, we have to talk about contraception. If she doesn't need contraception, now we could consider a standard dose sequential estrogen progestogen MHT, like for example, combining 2 milligrams of estradiol with dydrogesterone. Then again, she would come back after 3 months to find out if her menopausal symptoms are better. And then if everything is fine, we would see her back after 1 year. And then the DEXA scan also needs to be repeated after 2 years. So this was the cancer diagnosis during reproductive life stage. And now we have 2 cases, 2 gynecological cancer survivors that were diagnosed after the age of 45. Okay, so let's start with the first one. This is a 70-year-old woman. She was diagnosed with endometrial carcinoma, FIGO 1A, and she had surgery. She had an oncocardiology assessment, which was normal. She also had a DEXA scan, which was normal. And she came for first consultation because she had to discontinue MHT after the diagnosis endometrial cancer was given. And now, after having had surgery, she reports significant menopausal symptoms, and she would like to have her hormones back. So the question is it okay to prescribe MHT? So in order to find out what here the correct answer is, we could have a look at the British Menopause Society guidelines that were published last year. So you can see here on the right-hand side that we have 3 different colors. So if you see a green, this means that the benefits with MHT usually outweigh the risks. So, and you can see the differentiation between systemic MHT and vaginal estrogens. If it is a yellow light, this means that the benefits and risks have to be discussed with the individual patients, and it might be advisable to consider also get advice from a specialist. If it's a red light, then it means that MHT is not recommended, and non-hormonal approaches should be started first. So, and you can already see that women that have been diagnosed with cervical cancer, vulva cancer, vaginal cancer, for those systemic MHT and vaginal estrogens, they have a green light, which means that you can prescribe it. But now let's have a closer look at endometrial cancer. So women with a low risk and endometrial risk, here, at least the evidence that we have do not show that there's an increased risk of recurrence with MHT. So this is why there is a green light for systemic as well as for vaginal estrogens. However, if we have a woman with a high intermediate risk or high risk endometrial cancer risk, which is estrogen receptor and progesterone receptor negative, then in these cases, we do not really know about the risks of MHT. This is why there is a yellow. However, if we have a woman who has a high risk or advanced or metastatic endometrial cancer, then usually MHT is not recommended. That's why there is a red light for systemic MHT, but vaginal estrogens are most of the time still an option. However, if the overall oncologic situation is a palliative one, then of course we can always individually discuss if for improvement of quality of life, maybe MHT can still be prescribed. Interesting. And for our case now, if we think about our patient that I just presented to you, she falls into the category low risk, and this is why if we have a look at this green light here, we could prescribe hormones to her. Very interestingly, there are no data comparing continuously combined MHT with estrogen-only MHT in women with endometrial cancer. So let's go back to our patient. So she has a lot of menopausal symptoms and she would like to get back her menopausal hormone therapy. So what did I do? So I went to the head of our gynae oncology center and we discussed that in general, as you have seen on these green light slide, that she could get menopausal hormone therapy. However, he was a little bit cautious because of the G2 tumor. So he wanted her to start non-hormonal treatment options first. Those were unsuccessful, so that then after 6 months after her surgery, we then restarted MHT, and she received ultra low dose transdermal estradiol plus micronized progesterone 100 milligram orally per day, and she has this since about 3 years now and is doing fine. Now the second one. She is 46 years old. She was diagnosed with a high-grade clear cell cyst adenocarcinoma of the right ovary, FIGO 1A. We did an assessment of the hormone receptor expression, which was negative. She also received surgery, and as a comorbidity, she had endometriosis. And she also received chemotherapy, and then again, we referred her to the oncocardiology department, which was normal. She was also sent to the DEXA scan, which was also normal, and there was no genetic mutation. So she also came for consultation because of menopausal symptoms. And again, the question is, what would you recommend? So let's have a look again at the recommendations from the British Menopause Society. So again, as you know, we have different kind of ovarian cancer types, and these recommendations include ovarian, fallopian tube, and also primary peritoneal cancer. So let's have a look first at the epithelial ovarian cancer types. So if it's a high-grade serous or endometrioid ovarian cancer, then at least the data that we have do not suggest an increased risk of disease recurrence with systemic MHT. This is why we could prescribe MHT. However, if it's a low-grade serous ovarian cancer at stage 1, then non-hormonal options should be offered first, although MHT is not a contraindication as it's in yellow color. However, MHT is not recommended for women with FIGO stages 2 to 4 or recurrent low-grade serous ovarian carcinoma. What about borderline tumors of the ovary? Here, MHT should be offered to women who have menopausal symptoms following treatment for BOT and actively recommended for those with surgical menopause as a result of treatment for early stage disease. Germ cell tumors. Here, MHT should be offered to women who have premature ovarian insufficiency following treatment for germ cell tumors. And what about sex cord stromal tumors, which affect which are 3 to 5% of ovarian cancers? Here we only have limited evidence, and it's if it's a granulosa cell stage 1, then MHT can be discussed. However, if it's a stage 2 and higher, then it's not recommended to prescribe MHT, systemic MHT, but you see that vaginal estrogens are always possible. Our patient had a clear cell carcinoma, which means systemic MHT would be an option for her. Again, I talked to the head of our gynecology oncology department, and as she was also diagnosed with endometriosis, then she was recommended to use either tibolone or transdermal estrogen progestogen therapy. So now the next question is when to start MHT and how long should a cancer patient take it? So first of all, very, very important, MHT should only be initiated if there are no contraindications and then as soon as clinically appropriate. And if the case is complex or controversial, then it's good to wait until the histology is known and the full staging report is available. If a woman is receiving chemotherapy or radiotherapy, it's still possible to start with menopausal hormone therapy, and it should be used as long as the benefits outweigh the risks. And if a woman is really young when she starts or when she experiences menopause, then MHT should be given at least until the age of natural menopause. And vaginal estrogens can be started as soon as the vagina has healed from any surgical intervention. And then maybe you have the question if it's possible to add some testosterone. And of course, this idea is very close because sexual dysfunction is very often in women treated for gynecological cancer and obviously is multifactorial. And it's important that we also have offer the patients psychosexual services. So testosterone can be considered if the conventional MHT has been optimized and other causes of hypoactive sexual desire disorder have been ruled out. But importantly, testosterone should not be offered if estrogen replacement is contraindicated. So now I come to the take-home message. The first one, systemic MHT is safe in survivors of hormone-independent tumors and in low-risk endometrial cancers. And of course, decisions must be always individualized. Non-hormonal therapies are first in cases with uncertainty or high-risk histologies, but MHT may be considered based on symptom burden and patient reference. I think it's a good idea to assess ovarian function, the symptoms, and always take care of bone and heart health. Start MHT as soon as clinically appropriate and as long as the benefits outweigh the risks. And if you have a young cancer survivor with POI or early menopause, then MHT, if there are no contraindications, is recommended until the age of natural menopause. Vaginal estrogens are almost always safe and testosterone only for confirmed HSDD after optimizing estrogen therapy. Obviously, care must be individualized, multidisciplinary. I hope that you saw this also with me, that I always go and ask my colleagues who did the surgery, and guided by tumor biology, patients' values, and long-term health protection. Thank you very much.
Thank you, Petra. That was excellent and a very, very clear take-home message, which we can only echo. So it's really helpful, and thank you. We're getting quite a lot of questions coming through. Some of you are putting your questions in the chat. Please put them in the Q&A, otherwise they won't be picked up. Thank you. So now we'll move straight on to Dr. Jenifer Sassarini, who's going to talk to us about the management of menopausal symptoms.
Thank you, Tim. So I'll just share my screen. So hopefully you can all see this now. So thank you very much. So these are my disclosures. So I think I wanted to start with this because it just points out the importance of what we're talking about today. So we recently completed a James Lind Alliance priority setting in menopause, and this involved bringing together women or anybody with experience of menopause, clinicians and researchers, and prioritising the top 10 questions for menopause. And the first one was describing and evidencing the most effective non-hormonal therapies for menopause in women who couldn't or didn't wish to take hormone therapy or HRT. So I think it just points to the importance of what we're discussing today. I think it's also really great to recognise the amazing documents that we have available to us. We've only got a short amount of time today to talk about all of the non-hormonal options that are available, but I think there's some great documents out there, and these position statements from EMAS and the International Gynecologic Cancer Society, as well as documents on non-hormonal management, which we'll touch on some of these today, but also the British Gynae Cancer Society and British Menopause Society released a document last year looking at the management of menopause symptoms, particularly after gynecological cancer. And there's also been a TOG article released, which is the obstetrician and gynecologist for the Royal College of Obstetricians and Gynecologists in the UK, released a great paper on alternatives to hormone replacement therapy. And of course, there's the NAMS position statement from which a lot of the information that I'll share with you today has been taken. And I think it's just great to know that these documents are there because there's so many non-hormonal alternatives that women may wish to discuss with you. And you'll see that there's some available products that maybe don't have great data attached to them. And it's important to be able to discuss that with women. So, of course, when we're discussing alternative therapies, we always want, or any therapy with women, we want to discuss lifestyle measures. And so what might these look like and what actually are the evidence for them? So we often will talk to women about cooling techniques, or they may find this on forums that they're looking at or speaking to their friends about. So is there any evidence for these cooling techniques that might involve dressing in layers, sleeveless tops, breathable fabrics, environmental controls, fans, etc.? And there were 2 small trials, but there was no objective difference between using these techniques or not. Exercise is really, really important, and actually becoming more important even in the rehabilitation after cancer. There was a paper published just this year looking at exercise as a treatment option after treatment for cancer, and there were nearly 900 participants who had stage 3 colon cancer, and when they looked at exercise as a treatment or as part of their treatment regime, that showed a decreased risk of recurrence of cancer and a decreased risk of death. So exercise is hugely important, and we know about other health benefits in terms of mood and bones and reduced inflammation, etc. But in terms of exercise specifically for vasomotor symptoms, which is one of the most common symptoms of menopause, as you know, there are several Cochrane reviews that show insufficient evidence, to consider this as a treatment option specifically for vasomotor symptoms. In the McFlash trials, exercise and yoga did show small improvements, but again, the Menopause Society did not recommend this as a single intervention. Overall, studies tend to have a high risk of reporting bias and are quite heterogeneous, as you can imagine. But of course, exercise is still important in general. Avoiding triggers is an interesting one. There is a Chinese study that showed a positive association between alcohol and vasomotor symptoms, and anecdotally, women will describe specific things that they are aware of that trigger their hot flushes. But there's no clinical trials looking at avoiding triggers as an effective way of reducing vasomotor symptoms, although women will often tell you that that is helpful with their particular triggers. Thinking about weight loss, we know that obesity or increased weight is a risk factor for hot flushes and increasing frequency of flushes and also severity of flushes. And there is a randomized control trial that shows that decreasing weight from behavioral interventions will reduce vasomotor symptoms. And there's some suggestion that weight loss may have greater effects on vasomotor symptoms earlier in the menopause transition. And really interestingly now, with the increased use of these glucagon-like peptide-1 receptor agonists, there seems to be some suggestion that these may themselves improve flush intensity and frequency. And certainly there are receptors in the hypothalamus, which you know is the area that controls thermoregulation for these products, for these receptor agonists. And there's certainly potentially other benefits from these glucagon-like peptide-1 receptor agonists. And this is a fantastic paper that you can see at the bottom here that goes through all of the potential benefits, including benefits on bone, anti-inflammatory type benefits for Alzheimer's and Parkinson's disease even. And there was a study in rats who were ovariectomized who, when they were exposed to these agonists, showed an increase in bone strength. So really interesting products that are out there. I think it's really important to be able to discuss dietary supplements with women. These are over-the-counter things that women will ask you about. I'm certainly not an expert in these. I think it's just useful to know where to find the information so that you can look at this together and certainly involve your colleagues, as Petra was saying. I think that that's really, really important. These are often topical things that are coming to the forefront of herbal shops and forums that women are involved in. And so understanding a little bit about some of the evidence that's available or not available can be helpful. So soy has been, discussed for a long time with regards to vasomotor symptoms, and the evidence is pretty mixed. There's significant limitations in the studies that are available. Again, they're quite heterogeneous. The sample sizes are pretty small, short follow-ups, and they're surveys of symptoms rather than diaries. And be aware that soy itself is in the top 8 of food allergies, and so may not be suitable for many women. Pollen extract seems to be becoming quite popular, and there have been some improvements seen, but again, the evidence is limited, and so it shouldn't be necessarily recommended as a treatment option. And vitamin D has been studied, but again, whilst there's been some improvement in one very small study, it's not to be recommended again as a treatment for vasomotor symptoms. Lactobacillus acidophilus, as you know, is a probiotic. And again, there's been some evidence that it might improve quality of life, but it's pretty limited and again, shouldn't be recommended. In the US, there's a product called Estrovera, which I wasn't aware of until I started researching this talk. And it's a rhubarb extract, which is supposed to have estrogenic properties and has shown some improved symptoms, which include vasomotor symptoms, but the study was pretty limited in terms of its completion. Hardly anybody in the placebo arm completed the study, and so it's very difficult to see whether that should be recommended or not. Black cohosh is very well known and probably one of the most purchased alternatives to HRT. We're not really very sure how it works. Some studies suggest that it's estrogenic in nature. Others suggest that it's a SERM, so a selective estrogen receptor modulator, or that it might modulate serotonergic pathways. There's no evidence that it's any better than placebo, although some studies may suggest that for mild to moderate symptoms, it may be beneficial. So magnesium is very topical, and the biological plausibility in terms of bone, because it's important for bone, but also regulates GABA and helps synthesize melatonin. And so some studies have found magnesium to be particularly helpful for sleep quality, efficiency, and mood and anxiety potentially. But I think it's probably early days to say, although again, anecdotally, some women do find this helpful, but we need to remember the significant placebo response, I suppose, with studies in terms of menopause. So lots of other things, and I'm not going to go through them all, but it's just to be aware that they exist. that there are very few menopause-specific studies and very little in the way of safety data with lots of these products. They are not licensed or regulated, and so often what you're taking, you're not quite sure of the active ingredients. And also we need to be careful about the potential harm, and there's certainly been lots in the media recently about increased liver dysfunction amongst women, particularly who are taking lots of over-the-counter therapies. So just to be aware of what's out there. And the TOG article has got a fantastic couple of tables about all the different options so that you can look at this together with your patients. I think there's some great information in there about the possible interactions, because we need to remember that just because something is bought over the counter doesn't make it benign, and that it could interact with some medications that women are already taking. And really importantly, you can see that some of them might interact with warfarin, but also with tamoxifen. And if we're trying to keep women safe post-cancer, then we need to remember that just because it's over the counter doesn't mean it might not affect their endocrine therapy. So moving on then to non-pharmacological treatments, you'll all be aware of cognitive behavioural therapy, which is in the NICE guideline update for menopause. We know that it reduces the impacts of vasomotor symptoms, it improves mood, it improves sleep. In fact, cognitive behavioural therapy for insomnia is first-line therapy in the NICE guidance for insomnia, and it can improve sexual function. And this can be delivered either by a therapist or self-delivery, or in a group type situation. There is one RCT for hypnosis in women who have had breast cancer, and it seemed to reduce the frequency and severity of vasomotor symptoms, self-reported anxiety and depression, and sleep. And then acupuncture, there have been many, many studies over the years looking at acupuncture, and there's lots of controversy about whether acupuncture can be studied against placebo or sham acupuncture, and whether sham acupuncture is in fact actually sham, or whether there could be some effects from the sham needles, etc. Overall, they're been found to be no more effect, no more improvements in flush intensity, and maybe a placebo effect from the acupuncture. There's some interesting data coming out from electroacupuncture, and this may be more promising than traditional acupuncture. So what about things that we can prescribe for the women that come to see us? So there's a very small handful of prescribable medications that we can use, and they are all really targeted at vasomotor symptoms. You'll probably know about most of these already. Some of them, just because of the nature of the medication, may also have additional benefits, like the SSRIs and SNRIs that are used for vasomotor symptoms may have obvious improvements in mood, but we'll go through each of these in turn with some practical prescribing advice, just keeping an eye on the time as well. There's also some really great documents from the BMS on these prescribable alternatives, so I will just try and skim through them because we want to leave plenty of time for questions. So just to understand how these things work, we know about hot flushes are triggered heat dissipation responses because women who have flushes have this narrowed thermoneutral zone, and we think that many of these alternatives are working because they're targeting this area. We know that this narrowed thermoneutral zone happens at a time of decreased estrogen, but that also seems to upregulate serotonin receptors, thereby decreasing serotonin, but also increasing noradrenaline, and these may all contribute to this change in the thermoneutral zone. And so one of the first products, and the only licensed one in the UK for hot flushes, is clonidine, which is a centrally acting alpha adrenergic agonist, and it has a modest reduction in hot flushes, potentially similar to the placebo effect of some studies, but it does work in some women. And so if we are having only a small handful of non-hormonal alternatives, then it may be worth trying. It does seem to be less effective than some of the other non-hormonal alternatives, and it is limited somewhat by some of the side effects that women have. And we need to be cautious in people who already have low blood pressure or who may be on other antihypertensive drugs, because of course this is a pretty old-fashioned antihypertensive. And again, we think that it's how it works is centrally widening that thermoneutral zone, and certainly it did used to be used for post-operative shivering to change the shivering threshold. Practical prescribing, so you can all see that there. So starting at a low dose, But if after 2 to 4 weeks there's no improvement, then I would stop this. And the reason for saying that is that we do often see women in the menopause clinic who have been started on a non-hormonal alternative that hasn't particularly worked for them, but they seem to not stop the medication and keep taking it. So we need to be conscious that we need to stop these things if they aren't working, and that we may need to reduce this particular drug gradually, otherwise we may cause a rebound hypertension. There are lots and lots of different SSRIs and venlafaxine, the SNRI, which is the most studied probably of all of them. And they have, again, a sort of modest reduction in vasomotor symptoms compared to placebo. They obviously have some potential side effects. So the class effect, as we've said, can benefit mood, but the potential side effects might include things like nausea, dizziness, etc., but also sexual dysfunction. So taking a really clear history from women is really important, because what we don't want to do is improve one symptom but cause another problem. And so if that is a particular problem that women already have, and as Petra said, is often a side effect of cancer treatment, then we potentially, could be making that worse. And so we need to be cautious about that. No one is better than the other, and so really understanding the side effects that women have and how they're getting on with their particular medication is important. So again, we think this works centrally by increasing that thermoneutral zone. I'll not go through all the practical prescribing for each of the individual medications, because all that information is available in the documents that you've seen. What I would say, however, is be really conscious that SSRIs can affect the gut. So nausea can be a particular problem because of all the serotonin receptors in the gut, but just being conscious that starting really slowly, so even using very, very small doses and titrating that up, can make that much more manageable for women. And also just knowing that it's a problem, but it usually settles within a few days, can again mean that women are able to tolerate that in order to titrate the dose up. It's important, if women are on tamoxifen, to understand which SSRI is acceptable. So venlafaxine is okay because it doesn't seem to interact with cytochrome P450, whereas paroxetine does, as does fluoxetine, and as does sertraline. So citalopram and escitalopram or venlafaxine might be your choices if women are on tamoxifen. We're not quite sure how gabapentin works, but it does seem to work. It can be a really useful drug, just taking a 300 milligram dose at night if night sweats or flushes are problematic, and seems to be as effective in some studies as ultra-low dose estrogen, so maybe something to consider. Again, some practical prescribing advice. And pregabalin, very similar to gabapentin, but perhaps fewer side effects, and so perhaps better tolerated. Oxybutynin isn't in that BMS document on alternatives, as it's a relatively new alternative, but does seem to be really effective at reducing hot flushes, and certainly when compared to some of the other alternatives, performs really well at reducing hot flushes. And so if women also have bladder symptoms, this can be a really useful drug to use. So again, some practical prescribing advice. So usually just a small dose is needed. Dry mouth can be problematic. There is a patch version of this drug, and so that can often have fewer side effects, but still the benefits. Always ask about urogenital atrophy, and I'll not spend too much time on this because Petra's talked about it already, but it is important to ask. Urinary tract infections that are recurrent because of bladder changes are really important causes of sepsis in older women, and so it's really important to use vaginal estrogens if you can, and for most women this is acceptable. There are a small handful where that's not, and then we should be using non-hormonal alternatives. So the new drug on the market is, as you'll know, the neurokinin B antagonists. So Veoza from Astellas and Bayer will release their drug very shortly, which is again a neurokinin B antagonist, although slightly different, targeting two types of neurokinin receptors. And these drugs work sort of proximate to the gonadotrophin releasing hormone. They have projections into the hypothalamus where temperature is controlled, and this is why we think they work. These are some really early studies of the NK3 receptor antagonists. So Julia Prague and Waljet Diller's team showed a significant reduction in hot flushes, and then Karolina Skorupskate and Richard Anderson in Edinburgh showed that this works really quickly. So within 2 days in their study, women showed a significant reduction in hot flushes. So really effective. You'll have seen, I'm sure, already the Skylight trials from Astellas and the Oasis trials from Bayer showing significant reductions with these in hot flushes with these drugs. So a really promising alternative that we have now for women who can't use HRT or who don't want to. So I'm not sure I'll just quickly run through one case before we move on to questions. So this is AC, she's 47 years old, and she has a stage 3 low-grade serous ovarian carcinoma. So we know from Petra's talk already that HRT would be not advised in this case. She's had primary cytoreductive surgery and she's had some chemotherapy, adjuvant, and she's now at 18 months follow-up with no evidence of disease. However, she does have significant vasomotor symptoms, hot flushes and night sweats. Unsurprisingly, she's also got sleep disturbance, mood swings. She's also complaining of vaginal dryness and joint pain. So what will we do for her? Well, we know that HRT is contraindicated in her particular cancer type, and so we're hopefully going to improve her quality of life using non-hormonal strategies. So we want to talk about some lifestyle and behavioural changes. So exercise, weight bearing and resistance training, really important for bone health, but also for mood. She might want to supplement vitamin D, particularly if she lives in the UK where we don't get very much sunshine. And also think about her sleep hygiene. So CBT for insomnia, and there's an app called Sleepio, which we're fortunate enough in the UK to have free for women to use for cognitive behavioural therapy for insomnia. But she might also want to think about some non-hormonal pharmacologic options for her vasomotor symptoms. So she might consider venlafaxine, which might help her hot flushes and her mood symptoms. Paroxetine is, of course, FDA approved for flushes and sweats in the US. So that might be an alternative. If her symptoms are particularly bothersome at night and because of her sleep disturbance, it might be that she chooses gabapentin. Clonidine could be considered, or oxybutynin, and certainly Veoza could be considered, and we are able to prescribe that either privately or on an individual patient request on the NHS in the UK now. So really choosing something that would suit her, so that's a discussion to have with her. Thinking about genitourinary syndrome of the menopause and what she can use, thinking about pelvic floor physio, which can be really helpful adjunct. And of course, thinking about her bone health, does she need a DEXA, and thinking about therapy. And of course, I would discuss this with my endocrinology colleagues because they're the experts in the UK about recommending treatment. So I'll just stop sharing to give time for questions. Thank you very much.
Jen, thank you so much. That was a really comprehensive run through the alternative options, very complementing Petra's talk beautifully. We've got a number of questions which we'll come on to, so please carry on putting your questions in the Q&As. We've got about 15 minutes. We've had about over 300 people on this live on this meeting, and I know other people will be listening on catch up. It's good to see people from all around the world, and a particular shout out to people from Argentina, Colombia, Bangladesh and Siberia who've put their names in the chat. So thank you and welcome to everybody. So I'm just going to go straight on to the first question that we had through, which is starting really with you, Petra, because they were the ones that came through first. The question is, are meningiomas sensitive to estrogen or progesterone, and are some progestogens contraindicated?
Yes, indeed. Meningioma are officially a contraindication towards systemic menopausal hormone therapy. And what I have arranged with our neurosurgeon here at the university clinic is that he always wants to have an MRI of the brain, and he would like to have the hormone receptor expression analysis of the brain tumor. And then we discuss if he thinks that still MHT is an option. I personally think he has a look at the MRI and thinks about if he get it out again, if something comes back. And then he wants an MRI of the brain every year. But this is really an individualized approach. And I think this is a good example that it really makes sense to discuss with the other colleagues from other disciplines that are involved in the case. And And most of the time, I got a green light from him, so that I could
And I
start
think
on HT.
that's a really important message. And in fact, it's interesting. I think a lot more of allied specialties like neurosurgery and others are getting much more wise to the fact that hormone treatment is allowable, whereas before you just get a negative answer. Now they're much more prepared to give you more considered opinion, which I think is really helpful. Next question is, this covers quite a few bases. It's for you again, Petra. It's, why would you give progesterones in patients who've had a hysterectomy after endometrial cancer? And I know in your case history, the patient had endometriosis as well. And so there's several questions around that. And one is, why tibolone in particular?
Okay, so maybe I start with tibolone with this question first, because tibolone has estrogenic, progestogenic, and androgenic properties, which means that based on these progestogenic properties, you could also give it in women after hysterectomy with a comorbidity of endometriosis. And then the other question is why if it's necessary to give a progestogen or progesterone to a woman after hysterectomy with endometrial cancer. So as I already mentioned, there are no clear studies showing that estrogen, progestogen, or estrogen is better than the other. And in this special case, of course, you have on the pro side of estrogen only would be the breast health issue. But in this case, she really liked progesterone for her sleep. So this is why then in the end, we combined it again, the same way as she had it before the diagnosis.
Okay, thank you very much. I've a question for, I think for both of you really, but what about HRT after a patient with leiomyomatosis peritonealis disseminator?
Oh, okay, I have to reread the
It's basically where
diagnosis.
you've got the fibroids and you've got it's disseminated all over the peritoneum. It's a rare case. I don't
So,
know if you have
so
any.
is it like a uterine sarcoma? So is it this category? Then it would be a no. But to be
No,
honest,
I don't think that. I think it will depend on the histology. I don't know this. They don't specify the histology, but I think these are actually quite often benign. But they're just.
okay, okay, okay. So,
I think discussed with your
Yeah.
histologist, I think seems to be the answer to that one. Okay.
Yeah.
So there's a question here for you, Jen. Lactobacillus seems to show benefit on reducing vaginal candidiasis. Can it be considered as a treatment for vaginal dryness in a woman who, which facilitate, in a postmenopausal woman after cancer treatment, which sometimes facilitates vaginal candidiasis? I think the question is about vaginal candidiasis after cancer treatment, and would lactobacillus help?
Oh gosh. I actually don't know the answer to that question. Maybe you do, Tim or Petra. But I mean, I think if it's vaginal dryness and if you can use estrogen just to, if an estrogen's not contraindicated, then I would certainly use estrogen. If we're talking about treating candidiasis, then I don't know the answer to that. I would maybe use traditional therapies for that, unless they specifically didn't want that. So I think it depends.
Yeah, I mean, my reading of the question is that is specific to vaginal candidiasis and not specific to cancer survivors. So I think, you would, if they're postmenopausal, optimize the vagina with estrogen if possible. And if you use lactobacilli in your normal practice, then I guess you could use it then. There's no reason why you wouldn't be able to.
Yeah.
So perhaps a more mainstream question for you. Do you have any experience concerning the use of laser or other energy modalities as a non-hormonal treatment?
so
This is the Jen, yeah. And for
Okay.
the Jen, you mentioned this genitourinary syndrome and the menopause and
Yeah.
other options.
So I didn't mention it in the talk because I don't have any personal experience to answer that part of the question. But my understanding is because of lacking long-term data, it's not recommended by either the international or British or local menopause societies due to sort of lacking in the long-term safety data. I'm aware that practices are offering this privately, but I would be cautious because of the lack of long-term safety data.
Okay. So I'm just trying to scroll through all the questions. There's another question here, Petra, about adenocarcinoma of the cervix. Should we use estrogen only, or should we use estrogen and progesterone therapy?
So if the woman is hysterectomized, then estrogen only.
I guess the question is if there's one here that says patient was discovered during pregnancy and was treated with chemotherapy.
Okay, so the uterus is still there.
Is preserved.
Okay, so if the uterus is still there, then of course both estrogen and progesterone.
And the point is that the adenocarcinoma part of the tumor does not need additional progesterone if it's retained.
Okay, so the question is, if you still have the uterus, then I would give.
There's several different questions. I'm trying to pull them together. So basically, after endometrial cancer, we've said that there's no need for progesterone after it's been removed. And this is the questions regarding cervical adenocarcinoma. And in that situation, should we be considering progesterone?
So in general, adenocarcinoma of the cervix is considered the same as the endometrial cancer procedure. But again, if the uterus is still there, then of course I would combine it, because it sound like if it was a case where the uterus is still there. But if the woman was hysterectomized because of adenocarcinoma, then again we could also only give estrogens. Okay. But I'm not sure if I understood the question correctly.
I think that covers the answer to several different questions. It's all right. They've all been written in a slightly different way. So another question, I think this is really relevant for both of you, but Petra, you can ask this first. Why is MHT offered to younger women only until the age of natural menopause?
So it always says that at least until the age of natural menopause, and this is because, of course, in all these cancer studies that we have, we do not have follow-up data for years or decades. And this is why, because of safety, the recommendation is until the mean age of menopause. And of course, everything afterwards needs to be discussed individually.
Okay, thank you. Another question regarding to Jen about fezolinetant. Can we prescribe to breast cancer survivors? The leaflet says no.
So that is because those studies have not been completed yet for fezolinetant. So Astellas have the ongoing highlight study, which will address that question in women with breast cancer on tamoxifen or aromatase inhibitors, but the results are not available because the study is not complete yet.
What about elinzanetant?
So Oasis 4, I believe, have just published, or not just released, that is available now for women to use after breast cancer when using tamoxifen or aromatase inhibitors. So that will be available for that specific use, yes.
Thank you very much. And another question for you whilst you got the microphone, as it were. Why did you say the patient you discussed needed an annual lipid profile?
I think I meant to take that out, to be honest. But I mean, I think it's important, right? It goes to that whole cardiovascular risk. And we know that post-menopause, then cardiovascular risk increases. Different countries do things differently. We don't have a health check for women in Scotland. I understand this will be introduced south of the border for some women, and in other countries may be available. But I think it's really important to consider the whole picture holistically, and the lipid profile can change. And I think that is important to assess that.
And I also agree, because if we have a look at the paper from the oncocardiologists that were published, I think 2 or 3 years ago, so they have a very clear cardiology assessment in cancer patients. So I absolutely agree. I also do the lipid profile.
Excellent. One for you, Petra. Are there any data on androgens on the various ovarian cancers to allow testosterone to be prescribed?
I already saw this question, so I quickly double-checked the literature, and the answer is there are no data on testosterone therapy after ovarian cancer. Nothing mentioned specifically for ovarian cancer patients on testosterone in guidelines. But if we refer to the British Menopause Society recommendations, then the recommendation was that if there is no contraindication towards conventional estrogen progestogen therapy and the indication for testosterone therapy is given, then testosterone therapy would also be an option. So that would be my answer to that, although there are no clear studies on that.
Thank you very much. That's good. We're running out of time, but I just wanted to get both of you, I think, to finish off on this question. What is the consensus regarding the use of vaginal estrogens in women who are receiving aromatase inhibitors for the treatment of breast cancer?
So my answer is if non-hormonal therapies have not been effective, then we have this meta-analysis published this year, and my answer would be yes, ultra-low-dose estriol therapy vaginally is possible.
Very clear, thank you. Jen, you agree with that?
Yep.
Good, excellent. Well, that took a bit less time than I thought, so I think we can just quickly find another question. What about HRT in a lady with a history of osteosarcoma?
I think should be fine. It's not on the list of hormone-dependent cancers, so I think it's fine.
Yeah, I think there's a few questions about different rare cancers. I think basically the list is out there, and if it's not on that list, it's probably fine, or there's absolutely no data to go on. Okay, and then I've got one final question for you, Jen, which is what's known about fezolinetant therapy and in a patient with no malignant disease? And they don't mean breast cancer. So in other malignant, if they've got malignancy for other reasons, not estrogen positive.
Okay. I don't think we have any data because the
I
studies.
think this might refer to the possible comments regarding fezolinetant when there was some comment about fibroids, I think, at one stage.
Oh,
No,
no,
no.
sorry.
Okay.
Yeah.
Fine. As far as we know, no data on that one. So that's no reason why not to use it. Okay, good. Well, there's still a few questions that I haven't got time to answer, but lots of people saying thank you. And so thank you both speakers very much for really clear presentations and for fielding some fairly difficult questions from all over the place. And thank you all very much from all over the world for joining this, and hope you've enjoyed it, and it will be available on the EMS website later on. So thank you all very much.
Thank you too.
Thank you so much. Thank you.